Soy la doctora Isabel Enríquez, vengo del Hospital Regionalista de León, soy de la familia Encan, y es el tiempo en este momento de abrir el espacio para preguntas. Antes de iniciar con las preguntas, bueno, les compartimos sus equipos para traducción y queremos presentar a nuestro otro compañero de la mesa.
Se trata del doctor René Adams, cirujano oncólogo y viene de Francia, y obviamente considerando que estamos hablando de cáncer de colon y recto metastásico al hígado, donde el tratamiento multidisciplinario es fundamental, pues aprovechamos la participación de ambos ponentes para aclarar todas las dudas y preguntas que quieran hacer. Entonces se abre la discusión y las preguntas.
Do you need a translator?
Yeah, it's not.
It's not working.
No,
All right.
it's buzzing.
Okay. Voy por atrás, voy por atrás, voy por atrás.
Oh yeah, yeah. Wonderful. Thank you.
¿Alguna pregunta para los ponentes en este momento? ¿Is there any question? Please.
So how do you feel about integrating ctDNA for this setting?
Circulating free DNA.
Yeah, circulating free DNA into this metastatic setting in the adjuvant and especially metastatic setting.
So yeah, that's a very interesting question. So what I'm assuming, am I assuming that your question is mostly focusing on how to depict minimal residual disease?
Yeah, exactly.
Okay,
Yeah.
not as much looking for the mutation.
Exactly.
Okay.
Yeah.
So the answer is clearly we don't know yet at this point of time, on what these circulating DNA assays will help us much in terms of a predictive element.
Yeah.
So we know they have a prognostic element. We know if you still have circulating free DNA, similar to circulating tumor cells in the past, that these patients have a higher likelihood of a recurrence. In fact, those are the patients that will recur. So that's a prognostic element. The problem is, and where we don't understand, is what to do with these patients. Do we treat them with more chemotherapy? Do we observe them more closely? So we do not know. I mean, the fact that a tumor has bad biology and has a worse prognosis doesn't mean that my chemotherapy will change the outcome to the best. In fact, you can argue that those are the patients who are least likely to benefit from more. They actually benefit from less. And so at this point of time, the only way we integrate these minimal residual disease tests, so those circulating DNA, is on a clinical trial, on a trial that essentially addresses that question. Other than that, I have found not much utility for it in the clinic.
Thank you.
Another question. Usted habló un poquito del estudio New Epoch, about the New Epoch study, just for point the important part. I would like to know, do you think is there any role at this time for the anti-EGFR therapy in the case of a potentially resectable liver mets and without any mutation, KRAS, BRAF, and RAF, no mutated wild type? And is there any difference between right liver metastasis, or right or left side?
Yeah, so let's divide this between, first the stage. So I think for clearly resectable and borderline resectable, regardless of the mutational status sidedness, I wouldn't use EGFR inhibitors. And if the new EPOCH study with a clearly resectable shows us loss of survival, not just that the patients were progressing earlier, but they actually were living shorter. So their survival was shorter, even when adjusting for other adverse features. Now again, it wasn't powered exactly for that, but still the trends were concerning enough that one would question whether it adds any value. Because even if you switch those and you try to control for all elements and you move that curve a little bit up, it's not going to surpass the FOLFOX alone. So I think that that's a dead argument at this point of time, and I don't think it's going to add much value. Now, in the clearly unresectable, so those patients that are clearly unresectable, which you treat anyways, like metastatic disease, the only place that I would consider it would be left-sided tumor with a RAS wild type, BRAF V600E wild type, and HER2 non-amplified tumors. That patient could be considered for EGFR inhibitors plus chemo, although I remain relatively with a bias to folfoxiri, where you get similar response rate. You also get, and I'll tell you, I have another reason why I do that as well. You have a similar response rate. You also have similar depth of response. My European colleagues like the depth of response quite a bit. I think folfoxiri brings very similar depth of response. But more importantly, most of these patients will never make it to surgery. And with folfoxiri plus bevacizumab, I know that when I stop after 3 to 4 months, I can safely navigate them to capecitabine and bevacizumab for maintenance strategies. With the EGFR inhibitors, I have an incredible challenge trying to understand what the maintenance strategy is. EGFR inhibitors are incredibly tough. After 6 months, those patients will have severe hypomagnesemia, their rash is horrendous, and their quality of life actually deteriorates. They have eyelashes that hit the roof. I mean, that's what happens with these EGFR inhibitors. Now, if you have eyebrows like mine, they're gonna be looking down at you. So the point is that, you know, at the end of the day, you know, there's not much of a benefit in that setting to actually move EGFR. I don't know, Dr. Adam, if you have a different thought about this.
No, I would say that the European way of considering this problem is a little bit different than the US one. I mean, if we see your slide, your last slide, I agree for everything, but we don't see what are the patients that may be amenable to anti-EGFR therapy. And clearly, my view as a surgeon is that with anti-EGFR therapy, we induce a much higher shrinkage, a much higher, I would say, early tumor response, and a better depth of response. And if we see your slide, it's a pity to say to all the audience, there is no place for anti-EGFR therapy.
So my slide says there is a place in
Okay.
the unresectable.
Yes, but you said marginally unresectable, and this is important.
Borderline is, yeah, so the borderline I get a little bit concerned about because the biology is really, I'm not clear that most of these patients will be able to achieve surgery. Many of them are actually borderline, oh, sorry. I'm getting the wave from the back. So a lot of these patients actually, biology is probably more similar to the resectable than the unresectable. I can't claim that I understand in any shape or form why EGFR inhibitors had a detrimental effect. I'm just concerned about it to the point where I'm very, very leery about using these EGFR inhibitors anywhere except in the unresectable. And that's a biologic issue more than anything else.
Yes, and I would agree with you. For resectable patients, there is presently no place, because of the new EPOCH trial, no place for anti-EGFR therapy. I fully agree with you. But now when we come to what we call marginally unresectable, I mean, if we call them marginally unresectable, it means that they are unresectable. And at that time, we change the paradigm of treatment. And at that time, I would say the experience in Europe, and my own experience, is that by using a doublet plus anti-EGFR is inducing much more shrinkage, much more, I would say, depth of response, and much higher resectability rate. And as you know, when we cumulate all the studies done on anti-EGFR therapy combined with chemotherapy, the meta-analysis, and even also one randomized study, clearly demonstrated that by adding anti-EGFR to systemic chemotherapy, we increase the resectability rate and we increase the survival of the patient. There is no study, to my knowledge today, demonstrating that with bevacizumab or any anti-angiogenic factor, we can induce such amount of higher resectability, higher, I would say, survival rate. Now, what you mentioned, the Olivia study, we contribute to this. Of course, we do folfoxiri. And the shrinkage power of folfoxiri plus bevacizumab possibly is much more related to the folfoxiri way rather than on the bevacizumab. And so to say today, why not folfoxiri plus beva? I think it's a very good association, but it's a pity in a patient non-resectable with RAS wild type, even in left side colon cancer. I would agree for right, it's a little bit more debatable. It's a real pity not to use anti-EGFR. And what I know is that in the US, there is no place at all for anti-EGFR unless for very, very small niche of patients. In Europe, it's a little bit different, and it's what I have said. And even for right colon cancer, it is said by the ESMO, European Society Medical Oncology, it is said that when we want to induce a real shrinkage of liver metastasis in a patient liver only, even for right colon cancer, a multidisciplinary decision could sometime go also to the use of anti-EGFR, even if it's clear that with anti-EGFR in right colon cancer, metastatic, the effect is much lower, clearly, than with left colon cancer. So it's a small...
No, so I think we mostly agree. We mostly agree. I mean, that's what we're disagreeing on is that 20%, 25% of the patients who may be eligible for EGFR inhibitor because they have a left-sided tumor and all the right molecular profiling. So for those patients, if they're clearly unresectable, we actually agree. If they're borderline unresectable, so again, where they end up in the resectability range, I give you that if they're closer to the clearly unresectable, perhaps. But if they're closer to where they're more like borderline resectable than borderline unresectable, I mean, using semantics, then those patients, I still would avoid EGFR inhibitors. Nonetheless, I do realize also that there's this Atlantic divide between, the US and Europe about the use of anti-EGFR inhibitors, and it appears that at least on our part of the world, we're not as convinced about the utility of those. Now, that said, most of the data with anti-EGFR inhibitors has not been put to the test versus FOLFOX versus the triplet. That's why I advocate for the triplet for the FOLFOXIRI and not for a doublet when actually I need a response, because I don't think the doublet will give me the same response. And then I would add that the bevacizumab itself adds very little value. I actually am not even convinced that it adds much value to the discussion.
Just one point, because I don't want to take all. I will, absolutely. No, just the things that by discussing with my medical colleague oncologists, they said me, okay, you may use FOLFOXIRI plus BEVA plus Cetux or panitumumab and so on, but after what to do? And what we have to realize today, I fully agree with you. I like so much FOLFOXIRI as a surgeon, but many of my medical oncologist colleagues said me, yes, but when you are doing this, and then the patient does not respond anymore, there is no more drug to be used. And so we should sometimes be a little bit eclectic in the type of treatment we give to the patient. Just a comment.
It's a discussion for next year.
Yes. Okay, yeah. Well, thank you very much. Excellent discussion. Another one? No. Finish.